First topic is DARE. This is initially started by Dr. Adrian Taylor at Oxford. DARE is debridement antibiotic implant retention. He did not mandate at the time modular bearing exchange, or DECRA, whereas debridement exchange of the components, retention of antibiotics is what I consider a true DARE. Is this important for the panel, yes or no?
Yes. Yes.
Yeah.
Yes.
Yes?
Like if you can
Explain.
if you can remove the insert without breaking the locks,
All right.
then you try to clean it thoroughly and put it back in.
All right, so we'll go on to the next question. If it's if no modular parts available, your implant has been retired, you have a late infection, do you do a DARE, yes or no? Alberto, go down the line. You want to do a DARE, but you don't have the parts.
Yeah, so in this case, I'd still take out the actual modular component, as you said, and try and debride it as much as possible and put it back in. So yes.
What if you do that, you lose the locking mechanism?
Well, then in that case, you have to be ready to revise the implant. So if you have a retired mechanism, you got to be ready that may be completely worn away, and then you may have to revise it. So you got to come prepared.
So you'd be prepared for a revision every single time with a DARE. That's the most important part. You need to understand that sometimes a DARE is, you break things, you got to do it.
Yeah, especially if you don't have part of your implants available, you definitely need to be prepared to take everything out.
Sachin, you ready? You agree with that?
Yes, I do.
Everybody?
Yep, agree.
So everybody, it seems like there's a consensus. If you're going to do a DARE, every single part's got to be opened and removed. Yes? Correct? All right. What is the time cutoff between the symptoms of infection and doing the DARE? What's the cutoff? Everybody? Panel?
It depends actually on etiology. Like if it is acute infection after the surgery, then it is 6 weeks. But like I believe that DARE can be done even if a patient comes to you with acute homogeneous infection, might be 5 years after the surgery. If you have a specific factor, like I have once had a patient who had a wound on the leg.
What's your cutoff?
6 weeks.
6 weeks. 6 weeks and then post-op is 3?
Yeah.
Why? What's the difference?
Actually, if it is happening in the post-op scenario, then the cause has to be somewhere in the surgery if it is happening in the acute stage.
I think that's confusing between the two scenarios, which are completely different. We're talking about
Why? An infection is
hematogenous.
an infection. It's a sterile implant. It gets infected. Post-op is 3 weeks. Late it's 6 weeks. Organism's an organism. It sticks to metal. What's the difference?
So the actual pushback I'm going to have here is that if you look at so the idea of a cutoff is the idea that somehow you think that there's going to be a specific time and space where that biofilm is going to be immature or somehow not spatially distributed enough where you can't debride it.
Okay, so what's your definition? Let's go down the panel. When do you think that an infection in a joint becomes a biofilm? What?
3 hours, and therefore there's no cutoff.
The classic description is between 5 to 10 days is the window period, beyond 10 days, generally considered that biofilm will become more and more mature and the chances of success go down.
So do you think that you're curing a biofilm infection with an acute washout with a DARE? Anybody?
I think you are curing some of them. Not everybody relapses after a DARE, but it's hard to know who is who.
If you cure somebody with a DARE, are you curing an acute infection without a biofilm, or are you curing some of the people with biofilm?
The biofilm is like known to be setting up a forming within 24 to 48 hours, and it actually matures over time. So even if you are doing it within 5 to 7 days, you are otherwise dealing with the biofilm, but it's not mature yet.
Yeah,
Michael, do you think you can cure a biofilm?
I would say some people are cured with biofilm.
Really?
The literature has, counts acute sometimes out to 6 weeks, 3 months, and by then a mature biofilm has developed. But the literature then also shows that, the numbers aren't great, and depending on the organism, but failure rates are, or success rates are 50%, 70% with less pathogenic organisms. So it's not an impossibility.
So Ed, what's confusing about here is that there are the discovery of these non-culturable but viable bacteria that are on probably every sterile implant. So my approach with this is that in every case, in every operation we do, there is some level of contamination that occurs, And our host immune system, which is different due to a multitude of factors, has a certain threshold whereby if there are more bacteria than that threshold, there's an infection. So I think a DARE is not when you necessarily get complete bacterial eradication. It's when you get enough bacterial eradication below that threshold so your immune system can control with whatever is left, or you turn off that virulence factor that promotes propagation. We don't know when that is temporally, and we don't really know when all the host factors are. That's why I think this idea of a cutoff, you get so many different answers.
So a quick question then is, on this panel across the board, starting with Amar, do you think that every knee joint that you put in is contaminated with the bacteria? Come on, across the board, quick,
Probably.
Yeah?
I would say yes.
Yes. Yes. Yeah.
Yeah, can't escape it.
Say no.
Dan?
Yes, to a very low level, hopefully most of the time.
Very scary. All right. So DARE procedure, this goes more to Michael, intravenous antibiotics duration. How long should we do it?
Well, there's how long should we do it, how long we do it at HSS is
How long should you do it?
6 weeks. And
Why?
I would
And
argue
why?
that it doesn't
And
have to
why?
be intravenous. 6 weeks, it's mostly based on just historical tradition, what we've been doing. That 6-week protocol was developed out of HSS, is
Yeah.
what we followed. Now, I know the IDSA recommends between 2 to 6. However, trying to talk a surgeon into treating for less is sometimes very difficult.
Yeah.
We're usually 6 months. 6 months of some sort of antibiotic use. IV for however long Dr. Henry, the infectious disease doctors say we should, then switch over to an oral option if it's available.
I just want to point out, I always find it difficult when people say intravenous, because it's a bit disingenuous. I mean, it's really, there are plenty of oral antibiotics. So you should be saying high dose.
So, yes, I understand that point. All right, we're short on time. Long-term repeat DAREs. Adrian Taylor used to talk about the survival curve of infected total knees with repeated DAREs is better than exchange protocols. Do the panel members agree with that across the board? Starting with Dan.
Generally not, but I do think that there is a role for repeat DAREs in specific situations with our disc tract implants.
And that would be with what indication?
Extremely hard to extract implants where the treatment is worse than the cure effectively.
There you go. Okay, good. Across the board?
Same.
It would be infrequent to do repeat DAREs, but at the same time, you got to see what the organism is and what your prognosis is, what you're looking at. I mean, if you're looking at a 2-stage revision for a multiply resistant organism or a difficult organism, say gram-negative, you are looking at 2-stage revision rather than repeat DAREs.
Sachin.
So I think in my hands, repeated DARE is reserved probably for the not so medically fit patient who has probably got a well-fixed hinge prosthesis with long stems
go.
up in the femur and the tibia.
Yep.
And the whole morbidity of extracting the component is going to be far more higher than doing multiple.
So here you're saying if the treatment is worse than the cure, treatment is better. Okay, moving on. Single-stage exchange, we've talked about this a lot. Criteria for single-stage exchange for you, starting Amar across the board. Everybody chooses single-stage exchange for hips or for knees.
I mean, as you mentioned, when I do cementless knees now, that's what I'm aiming for.
Yep.
I'm doing a lot more cementless knees, which I know are not available yet in India. But if it's a cemented knee, I generally will do a DARE, and then later on I'll take it out.
Okay.
So my criteria for single stage, if I'm doing it in an acute setting, cementless implants within the first 6 weeks, take them out, I'll do a single stage right there.
Okay.
In a chronic setting, I've used pretty much what the endo clinic is. You know what the bug is, a good host, a possible suppression, and then favorable results. I would use cement.
Good host, easy bug, yes?
Yeah,
That's
what I agree.
Good soft tissue envelope as well.
All right.
Everything has to be going for you.
For the panel, what's a good bug?
Coag negative staph.
Coag, negative staph. Anything else that's good?
Not Staph aureus.
Not Staph aureus. Gram negatives, all out? All out?
I
Okay.
disagree with that. I have not found in my practice anyway to have that much trouble with non-Pseudomonas gram negatives.
Not fungal.
I agree with that. I mean, the ones that we know are bad actors are, of course, fungals. We know that the enterococci are bad actors, and to be honest, coag negative staph are often bad actors. Even
Can
though
be.
we think they're weak, they're not that weak.
They just persist. They don't.
Persist, that's the problem.
Yeah, right. So if you're doing a single stage exchange, whoever does it, do you use a cone where it's porous coated? Anybody? Or do you fill it all with cement?
So my idea really with the single stage is that you're doing such a radical debridement that you've got clear margins. So in essence, it should be okay. It should be okay to use a cone fixation. Otherwise, if you're worried about that, why are you putting metal in at all? So to me, I think it makes sense.
Okay. Anybody else?
I agree with that. I think if you're going to go for it, go for it. And if now and then you fail, okay, you got to take it out. So it's the same as a two-stage.
Okay.
I think, sorry, Ed, I'm interested to see what Amar thinks, because then I think all of us may be talking about still using some antibiotic cement hybrid fixation to fix, obviously, the tibia with the cone. Amar, you're really thinking about all cementless if you're going to do that, correct? For a single stage, you're comfortable with that? No need for antibiotic cement?
I mean, that's why I love using the sleeves and doing cementless fixation, because if you get early infection, you know, it shouldn't grow in and it comes right out. And
And
so
then start over.
then start over, exactly. So that's, you know, and then I just have to find some gaps where I can put in some antibiotic cement just to, you know.
You know, I think the idea that you have to have antibiotic cement in a one stage is being challenged a little bit by the data from North Carolina, where they are doing the one stage versus two stage protocol, and at least in the hip, they're doing all uncemented implants.
Yeah, but their
And they haven't
antibiotic
done that.
durations are up to 1 year.
No, they're giving a lot of antibiotics. We got to wait and
Yeah, yeah.
see. But
Wait.
the point is that I'm not sure we know right now how much the cement, antibiotics in the cement matter. I mean, we all do it, but whether it matters, I'm not sure.
Okay. 1.5 exchange, for a description, generally treat like a single stage exchange, definitive total knee implants, maybe destination spacers, as Michael has talked about, post-op antibiotics for surveillance. Is high-dose antibiotics and cement useful or not for an infection? Yes or no?
So I do it, and I haven't had a problem with fixation failure yet.
Yep.
So I'm just falling more and more in love with this protocol every day.
Are you going higher and higher doses of antibiotics?
I'm doing about 6 grams.
Yep.
I'll usually use, you know, for reimplantation, it'll probably be 2 bags, maybe 3 bags of cement, and it'll be somewhere between 6 and 8 total grams of antibiotic in there.
So our lab studies in animals show that the spacer with cement is really, really good at protecting itself. It does not necessarily leach out and sterilize the soft tissues, so I am not really convinced that it really is a big game changer. That being said, I still use, but I won't put 4 or 5 grams. I think the Mayo Clinic's published several studies showing the concern about acute kidney injury. You have to be careful about putting in a lot of antibiotics that can elute quite quickly, so you have to just be aware of that, and you should look at that literature.
Taylor, you agree with him?
Yeah, I've been putting in 4 to 6 grams per bag.
Rest of the panel?
Yeah, I think that putting high-dose antibiotics in there makes sense if you're going to do it. But I would actually say that the idea of the 1.5 spacer, where you're putting in kind of a poorly fixed implant, is a fallacy. I think that's just a completely crazy idea. It's the worst of both worlds. So in my opinion, if you want to do something, do it one stage, but do it with higher dose antibiotics if you want to do that.
All right.
Why are you saying it's poorly fixed? It's not poorly fixed.
Well, they're not revision implants for the most part.
And then it goes on to the discussion, what is really, truly a 1.5 exchange?
Isn't that just a spacer where the patient's happy and doesn't want to come back for reimplantation, and then you go ahead and call it a 1.5? I mean, at the end of the day,
Let's go through this case really quick. Okay, gentleman, BMI 27, knee didn't do very well, swollen, aspiration by local orthopedist, grows staph. He has possible erosion, swollen knee, continues to be swollen. Here's his numbers on his aspirations. His first numbers, culture's negative, DNA negative, numbers are elevated, repeated, still a little bit elevated. What do you do with this situation? Treatment this is real life orthopedics. How do you approach this across the panel? How are you going to do this?
Yeah, I'm taking this knee out, and I'm going to put in a 1.5 spacer.
2-stage.
Yeah, I would lean towards 2-stage.
This will be a 1.5.
I think this is a 2-stage.
Yeah, kind of 2 stages because there is osteolysis.
Dan?
2-stage.
Okay, so this is what I did. Remember, incisions, like a whole panel talked about large incisions around the world, go around and debride it, techniques to tap it out however you want to do it, to tap the implants out, and then was stabilized with a 1.5 exchange. Again, high doses of antibiotic cement. I use a lot higher, more like 7 grams, but to do that, I add 11 cc's. I just figured it out, 11 cc's of saline, then mix the monomer, and then put him off. And then he goes home on post-operative day 5, oral antibiotics only for 4 weeks. So this is where we differ from the East Coast, from the West Coast, antibiotic brachytherapy, which is treatment of antibiotics in the hospital only, no PICC lines. I haven't used a PICC line since 2019. I send them home with oral antibiotics for 4 weeks. And in 1.5 exchange, not all 1.5 implants need revisions. They can last a long time if you use cement technique like Amar has talked about. Allows that patient to return to work, maintain their financial stability, maintain their insurance for subsequent reconstruction.
But Ed, isn't that really a one stage with just high-dose antibiotics in the cement? I mean, you
so is
used
a
revision
single-
implants, you had stems, you had good, well-fixed implants, you had good cement interfaces. That's a one stage.
So if you add antibiotics, you reduce the cement fatigue strength by
But that's
over-
a pretty minor effect. So I would
It's a
just say
big-
that's
it's a
I'd
big
say that's a
effect of
one
the
stage
overload.
with high-dose antibiotics, not a 1.5
So
stage.
is that where we should go, where the cement's going to get loose at 7 years and then change it?
I don't know. We don't have any data that says that.
Well, what's your gut say?
My gut says that probably the effect of the high-dose antibiotics on cement strength is not going to be a critical factor in how well they hold up.
So you think high doses of antibiotics, 7 or 8 grams, will last 8 years?
As far as I can tell, I haven't seen any data that says it won't.
Okay.
With respect, though, Ed, I mean, you have extremely good experience. You know how to do a very thorough, meticulous debridement. I guess the question I have here is that we're putting all these high-dose antibiotic cement here. The idea then is that the tissue you are leaving in, the bone that you are leaving in, is not getting any blood supply. It's not being reached by the intravenous antibiotics, so you need local antibiotics to kill it all. This is what's so confusing about me, because obviously that's not the case. The bone that you have in there is still alive. So all the antibiotics you're going to be giving intravenously is still going there. You've done an incredible debridement. Isn't the debridement more important than the antibiotics? I'm just pushing back here. I love the reconstruction.
100%.
I'm just saying, you know.
100%. But if you have dead bone and tissues that don't have perfusion, what is better to treat the infection? Local diffusion and elution, or is it IV antibiotics that don't necessarily get into the envelope? And that's why I'm going to local therapy, and that's my thoughts with that. Next question, or next topic, native knee bone infection with arthritis. Septic arthritis progresses to active osteomyelitis. What's the best treatment? Take it out, debride it, try to cure it. Anybody?
So I've done a lot of these now. If you try to wash it out, these knees get super stiff, and you've just ruined this person.
They
So
do. Remember that. Remember what Amar just said. They get ruined.
Yeah, they get ruined. So I put in the 1.5 spacer, like a high dose antibiotic knee replacement, and they've done well. They don't get reinfected, and they have a functioning knee.
Taylor, what do you think?
Yeah, I think it's case to case, but I mean, that sounds reasonable given.
Okay, let's go through this case. Antibiotic therapy, well, I don't know where I missed the antibiotic brachytherapy. We touched on that 1.5 exchange. Whoops, I'm going the wrong way. Forward. Let's go.
Say you, Michael Henry.
Forward. Here we go. Here's a patient, Pkc in the knee. He's had 4 surgeries on his right knee, continues to have an infection. This is what his knee looks like. He has end-stage arthritis. This is what his MRI looks like, active infection. Remember, fungal infections go through the ligaments and into the bone. I was only get a little bit of fluid. Microgen DNA is negative on posaconazole. What's the treatment on this? Active.
Two-stage.
I would say two-stage.
Stage.
Okay, moving on. This is what I did, a 1.5 exchange. I use antibiotic-loaded calcium sulfate beads in the canal, in and around the joint. I believe that local therapy is the way to treat it. So in this case, I treated him with oral posaconazole for lifetime. This is all the surveillance data is all normal. He's pain-free, continues, and this is the whole point that Dan was talking about. Destination spacer, high-dose antibiotics. Here he is at 3 years. He's working as a rancher, continues to be pain-free. This is with a modern cement technique. Okay.
Sorry, and then chronic antifungal suppression.
Because he
rationale
has
for that is-
pulmonary coccidioidomycosis that they can't cure. He has a lung abscess and they don't want to take it out.
So then if he didn't have that, would you be still giving him lifelong suppression?
No, I would stop. But the question with fungal infections in the lungs, did they ever reactivate? And that pertains to a lot of cases in India as well. Okay, native knee infection. Native knee after fracture-related infection becoming more of a problem we see in the United States. More seen with polymicrobial and fungal organisms. How do we address the treated fracture-related infection when a total knee is required? So do we do those with single stage or we do those with 2-stage? What is your protocol across the panel? Start with Amar.
Yeah, again, I'm going 1.5 nowadays. In the past, I would have done 2.
1.5 and leave it if it's okay. Yeah?
I would say this varies on the organism, for sure.
What organisms do you
Or I would
not-
worry about MRSA. I would be doing that in stage.
MRSA 2, what else? All the gram negatives?
Certainly Pseudomonas, or, ESBLs, things that don't have. good-
ESBL, yep.
2-stage for me.
Yeah, generally 2-stage still, but
2-stage for sure.
2-stage definite.
2-stage for sure.
One of the things
Two-stage
I've
except
noticed-
extenuating circumstances.
The extenuated circumstance being the host?
Yeah, the host.
Yeah.
One of the things I've noticed, which, I don't think the literature is necessarily borne out, but my hip infections tend to be younger.
Yeah, isn't that
The
interesting?
knee infections tend to be older people.
Isn't that
That's
interesting?
why I'm into the 1.5, right? Because
Yeah.
they're 75 and plus. I'm like, they can't tolerate.
Yeah, right. Case, here we are, unstable knee. She's on faculty, prior OIF of the tibia. Here for you, Michael, Lamentasporia prolificans, 20% mortality.
Not good.
Not good. What do you do? 2-stage or 1-stage? Whoops, sorry, wrong way. Unstable knee, hyperextension. This is a fracture-related infection treated with that experimental CDC antifungal, voriconazole and beads. And now she comes to me, unstable knee, soft tissue loss. You do this single stage versus 2-stage. All the numbers are normal, 5 months off of treatment.
I would, just because there's zero literature with that particular fungus,
By the way, Lamentasporia, bad bug.
I would do this in 2-stage and very slowly.
Anybody else?
I don't disagree.
I would send it to Alberto.
All right. So here we are, single stage reconstruction. I use what Alberto talks about. I do a radical debridement, take the cone reamers, ream all that bone out that was in there, and then I lavage it, full strength peroxide, betadine. I'll show that a little bit later on in a couple minutes. And she was treated with a single stage, no cones, with standard dose antibiotic lotus cement and antibiotic beads. Complex stabilization, large segmental resections. How do you stabilize? With these large multi-failed implants, multi-revised implants, is an amputation better, do you think? Taylor?
yeah, I'll say, you can use an X-Fix. It's uncomfortable. It's the full leg. You can rarely talk a patient into an amputation if they're not ready to have it yet, though. So I think a lot of people would rather wear the fixator for a while, try to treat it. Sometimes that is a helpful realization to them, where their life and leg is headed.
How long does it take to talk somebody into an amputation? Electively?
3 to 6 months.
Easily, 6
Panel?
months plus.
6 months?
Long
Easily 6
time,
months.
surely long time.
Depends how long it takes to see Taylor.
If the distal limb is functional, we should always try to keep the limb, because amputation has its own complications, as we have seen in previous presentations.
Yeah.
I think it's also important to say that I felt comfortable using distal femoral replacements as spacers. They're expensive, trust me.
They're
It makes
expensive,
sense in
and your administrator is going to be right all over you, just like me.
The internal-external fixator works really well, though. I don't know if you guys are familiar with that. We put an external fixator inside, coat it all with antibiotics,
And
and
then let 'em-
then that'll hold up for a number of months while you're making your decisions.
Yep, all right. So here's the case, failed reimplant number 2, 2 flaps, lateral vastus lateralis, extensor deficient, refuses amputation. This is what he looks like right there. He's got staph epi and Klebsiella, as you know, bad bugs. What's the treatment, gentlemen?
Yeah, I'm trying to talk this patient into an amputation usually. Can you show me since I want to see the rest of that femur. So yeah, there's enough femur to do an osseointegration there. And maybe she's never heard of it. Maybe that helps her change her mind and make her decision.
Do you really find it's more the function of the foot? They always look down at their foot, and the foot's normal. And they say, I don't want to lose that foot.
See, that's the problem with these cases. Their foot works, they have normal sensation, they have normal circulation. It's just the knee. Why can't you just fix it?
Yeah, I say, yes, I know your foot works, and everything up until your hip doesn't work anymore. This entire segment of your leg has failed you now. And I mean, look at this. This is, yeah.
All right, so treatment here, endoprosthetic fusion. This is where I use the modular endofusion device. It uses a stabilizer. Sometimes it's permanent. Antibiotic beads, you know, that's the West Coast side of local treatment. I cut the stems to what I call the Gerke 125. He taught me 125 millimeters with a fat stem, keeps everything stable and is just the right length to take out and debride the cement. So again, antibiotic beads are in there. Why do I use antibiotic beads? Because antibiotic elution efficiency from cement is only 5 to 8%. Beads completely dissolve within 4 to 6 weeks. Beads always dissolve within the canal. They never form bone. This is showing the leach effect from cement. It's only 1.5 centimeters. So that's why Amar.
Have you, my experience with beads is that it just causes a weepy drainage, and I got away from them because of that.
Everybody about beads across the board, really quick.
Drainage, drainage, drainage whenever it's left in the joint.
So, yep.
Yeah, certainly for more like osteomyelitis, bone infections, I've headed more towards like Cerament G, which doesn't drain as much.
So what I say with beads is that it's leak, 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 aspiration, 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 post-op, get it controlled. And it's not, the bead leak comes from the acidity from vancomycin when you add to it. Tobramycin buffers it. Vancomycin has a pH that's down around 4. That's why you leak. All right. These are aspiration studies, and this is what I want to show to Alberto with DNA studies. So I'm aspirating, 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 get the beta fusion down. DNA is positive post-op. Why? Because bugs are still being killed. DNA picks up live organisms for up to 24 hours, showing that even 10 days after that resection, it still has positive organisms by DNA, which are going to be culture negative. That's a learning point for me. So lavage agents, we're almost done here. What do the panel members recommend in terms of lavage for infection? Across the board.
I use betadine peroxide.
Full strength?
No, diluted.
Diluted.
Full strength betadine peroxide.
Yep.
Diluted betadine and peroxide.
Normal saline with vancomycin.
Normal saline with betadine.
That's betadine and peroxide.
Dan?
Dilute povidone iodine.
Povidone iodine only. All right. Irrigants?
I have done these like double, triple dares where I've used like Dakin solution.
Yep.
It's crazy, but yeah, I've done it.
This is mimicking what Alberto said. This is from our lab. It's in the middle of being written up. We tested everything across the board, not in vivo, but in vitro to see what is the best agent. You can see Surgifor is not good about planktonic cells. If you look at biofilm, not all of these agents, including Dakins, kill biofilm. And if you take the finalist, which is the hydrogen peroxide, betadine, tested against Bactissure, which is the most manufactured one, tested against Staph and Canada together, you find out that the only winner in this is full-strength hydrogen peroxide and betadine, which is a radical debridement, sitting in the vase, and then you put it in, mix it in, fizz it up. And remember that betadine and hydrogen peroxide will kill your own cells, including your own immune cells, so you put it in for a couple minutes, 3 minutes, and then lavage it out and make sure it's absolutely spotless before you go. So with that, for successful treated total knee PJI, how long should patients be treated with oral antibiotics? Preset, ID specialist, based on surveillance or lifetime? We're out of time across the board.
ID specialist.
Lifetime.
ID.
What's that? Who said lifetime? Why?
I mean, I think the risk of a reinfection, if it were me, I would take it forever.
I would say your biome in your gut is going to create a resistance gene within days.
That's true, but I don't know how clinically important that is. When patients fail DARES, it's rarely
You get a
resistant
plasmid,
organism.
you get in there and you get a resistance to that organism.
But you rarely get a relapse with the resistance of that infecting organism to begin with. Most of the time, it's just from another bacteria, which is why I don't worry about that as much. Whether or not long-term or...
Should it be lifetime?
It is with us. Should it be? I don't know.
Okay, good. I think that's it for this. We move on.